Our goal in this very brief tape is to discuss psychiatric formulation and its relationship to psychiatric diagnosis. The first thing to understand is that psychiatric diagnosis is only the first step in the evaluation of a patient. I don't trust clinicians who don't know psychiatric diagnosis, but I equally don't trust clinicians who only know psychiatric diagnosis. A psychiatric diagnosis is just the beginning of a thorough evaluation. And Hippocrates 2,500 years ago said, it's more important to know the patient who has the disease than it is to know the disease the patient has. The first step in getting to know the patient is to understand, why are they coming in now? Very often they've had symptoms of one sort or another, or one level or another, for a long time. Why now? What specifically has triggered this current visit? That's often a very good clue to help us determine what will be the best ways of helping to deal with the symptoms. It's important to understand the social context and the stressors that the person's experiencing. Have they just lost a job? Has there been a recent divorce? Is one of their children having a great deal of trouble? Understanding the social context helps us to decide which treatment will be most likely to be helpful, and particularly those people who come in with major stresses very often need treatments directed to alleviating the stress, providing support, more than giving medication or even giving psychological treatment. I think it's also very important to understand the severity of symptoms. Most mild to moderate psychiatric conditions are best treated with watchful waiting, with psychotherapy, and medication only as a last resort if everything else hasn't worked. Many people come to us on the very worst day of their lives. And even if we do nothing, watchful waiting and normalizing and giving encouragement, advice, and support, they will get better. And it's better that people get better without treatment if they didn't need it in the first place. For those people who do need treatment with mild to moderate symptoms, psychotherapy would be first line. The psychotherapies that are available are very various: cognitive behavior therapy, interpersonal therapy, psychodynamic treatments, family treatments, group treatments. There's very little indication that one treatment is clearly superior to the others. And so the patient's wishes, the therapist's skill, the time available, the urgency of the problem, all will determine which treatment is offered amongst the various ones that are available. Basic to all treatment, though, is the relationship between the therapist and the patient. A good relationship predicts a good outcome, regardless of the technique used. And a bad relationship won't work no matter what technique is used. So that's very important in the early sessions. The major goal of the early sessions is to establish a good relationship, to make sure there'll be a second and third session. And the therapists who are most attentive to technique are often least attentive to the relationship building that's crucial in having a good outcome from psychotherapy. The use of medication should be reserved for those people whose symptoms are fairly severe, fairly chronic, not amenable to watchful waiting, not responsive to psychotherapy, a last resort. The placebo response rate in people with mild to moderate psychiatric problems is enormous, almost as high as the treatment response rate. So among people who have a stress-related transient problem with lots of psychological conflict as part of the picture, medication will not be much more effective than placebo and brings with it all of the added side effects and complications. When a patient responds to time or psychotherapy, when a patient is on medication and they get better, it's very likely that it's just time that was influential in producing the improvement, but they don't know that. So many people spend years or a lifetime on medication they don't need, with all the consequent complications. It's very important not to begin therapy too soon in order to determine whether time, advice, psychotherapy can be helpful instead. The best way of understanding formulation is that it must be complete, biopsychosocial. Formulations that just focus on the biology and the use of medication, or that just focus on psychological issues, or just focus on social issues, are much less likely to be effective than formulations that combine a rounded view of the patient, a three-dimensional approach to their problems, and a strong relationship aspect to the doctor-patient healing relationship. Good formulation is the beginning of a successful treatment. It should also be discussed with the individual. People will comply with and participate more actively with treatment plans that they themselves have approved or even developed. So in summary, a successful formulation is usually the most complete formulation, one that includes knowledge about the patient's diagnosis and its severity, but is not restricted to it. It also focuses attention on the social situation the patient confronts, the stresses, the potential supports. It's very interested in the patient's psychology, understood through empathic questioning and the development of a strong therapeutic relationship. It really is that relationship that's most essential in a successful treatment. And the treatment will be most successful if the patient's an active participant in negotiating which of the possible options will be tried and in what sequence. A good formulation is the basis of an excellent treatment. And I think we can be very, very effective in our work to the degree that we get to know our patients and share decision-making with them.